The need my team was working on during the Biodesign Fellowship was an office-based treatment for nasal septal deviation. We stumbled upon this need after observing in the ENT space and noticed that while many of the treatments or prior surgeries in ENT had been moved out of the OR and into the office, nasal septal deviation as a pathology had fundamentally not been changed. Patients were still undergoing open surgery, and so we really challenged ourselves to see if we could come up with a less invasive way to still treat the same problem. And so what we developed was an office-based, minimally invasive needle delivery system to mechanically correct nasal septal deviation. In terms of our reimbursement analysis for our project, there were two main questions we had. The first was whether any new solution we could come up with would fit within the existing CPT code. The second question was whether it could generate sufficient revenue in the clinic to really get the physician's interest. And we noticed that in looking at other office-based solutions in ENT specifically, there was a lot of sensitivity around changing the economics of moving something out of the OR and into the office. And so we spent a lot of time understanding those dynamics. In terms of what resources we used to answer that question, there were a number of things we looked at. The most useful thing we found was really looking at the CPT coding manual. So this is a coding manual that explains really all the basics about the code. And one of the most important things we looked at there was what's called the clinical vignette. And so that's the step-by-step guide that describes what the procedure is. And for you to be able to use an existing code, your new procedure has to fit very well or very closely within that vignette. The second resource we used was talking to a number of actual coders, medical coders at Stanford and elsewhere that had experience working with these codes. And so we went to them and really sought to understand their interpretation of the code and proposed to them essentially a mock procedure or operative note of our design procedure and asked them, would this fit if you were looking at this code into the existing framework? And then the third resource that we used was just talking to ENTs. They're very much aware of what the codes are, what the qualifications are for those codes, and we proposed our kind of basic procedure to them and asked them whether it fit within the code. What really got us confidence that what we were working on would fit in the existing CPT code was talking to numerous coders and numerous ENTs. And after we began to hear the same thing from multiple individuals, we really felt that we were validating what we were working on would fit within the existing code. In terms of working with a consultant, we really wanted to challenge ourselves to understand the code ourselves first, and then also knowing that consultants are difficult to find and expensive, we really wanted to validate with multiple ENTs, with the coders first, and really gain that knowledge ourselves before going and talking to a consultant. But after we felt that we had that base knowledge in place, we really felt that the next level of understanding that we needed did require to have a consultant, and ultimately went and found one. What we found is that the value of fitting in an existing CPT code is really understanding how much time and money it's going to take, how much time and money you really need to be able to take your product to market. If there's an existing code, that process is typically less expensive and quicker. And if there's not an existing code, that's not necessarily a problem, but it's really important to understand that early on that you're going to need to go through a series of steps, have the dollars and time in place to be able to get that new CPT code.